And we are live in 3, 2, 1. Please start. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on prostate cancer expert consensus meet. And with immense pleasure, I would like to welcome Dr. Chandragouda, who is Associate Director, Medical Oncology, BLK Max Super Specialty Hospital, New Delhi, for welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you very much. Thank you, AstraZeneca, first of all, and thank you all of you for making for making this busy evening the academic one, as we'll be discussing the process consensus expert meet. As we know, prostate cancer is definitely a multidisciplinary meeting, multi approach that you need to follow for a better patient outcome. And we have seen a sea of changes in the last 10 years or so, where so we've gone a long way from radiation to definitely surgery to a lot of systemic modalities in the hormone sensitive setting to a CRPC. So without much ado, I would like to welcome Dr. Anil Kumar Saini, sir, who is a senior director and head of the department at Max Salimabad, to take over further as a chairperson and invite the next speaker for the session. So over to you, sir.
Yeah, good evening, friends. Can you hear me?
Yes, sir, you are audible.
Okay, so it's really a pleasure to be with you all today evening, and I must thank Dr. Chandragouda for his kind invitation. And this is really a very live topic, because prostate cancer, as you all know, the incidence is increasing, and more in cities like metro cities, where preventive health checkup has created this PSA awareness, and all the people, even the health camps and the labs, which are doing now the executive health checkup. So people are really coming out to get this PSA done, and that has created a real environmental and the social change, that people are coming to us for this. And we are detecting with biopsies these cancers quite often, and it is not that we are only getting the early cancers, we are getting the late cancers too. And there comes the role, as Dr. Chandragouda has said, the role of multidisciplinary team. And we have a very well-known speaker today, Dr. Shikha Haldar, and she is known to the community which is dealing with these oncology teams. And I would like to invite her for her deliberations on multidisciplinary team approach in management of prostatic cancer. So with this, I invite her for the deliberations. Dr. Shikha Haldar, please.
Thank you, Dr. Vashne, and thank you, Dr. Chandragouda, to have given me this opportunity to talk on multidisciplinary approach. So can I share my slides?
Yes, ma'am.
Is it visible?
Not yet, ma'am.
I think it's on my desktop. You'll have to give me the this thing to share. Is it visible?
Share screen option, you just go through that, so share it and then go minimize and then share it. Share screen. Arrow down, just tell.
Ma'am, can we share your slides from our end?
You have my slides? I don't
yes,
think...
we have your slides.
Yeah, sure.
Yeah, sure, ma'am. You just have to say next. Okay?
Okay.
Yeah.
Have you put on the slides? No, I cannot. I have made my own slides. This is your slides, I think. So, can you give me your screen sharing? It is not coming like, okay. Yeah, I got it now. Now, can you see my slides?
Yes, ma'am, we can see your slides. Just make it screen, ma'am.
Yeah, sorry. Well, I hope it's visible now.
Yes, ma'am.
So good evening, everyone. So my talk is on role of multidisciplinary team approach in management of prostate cancer. Whether it is beneficial or is just wasting our time, we'll be just going through that. So first, so how is it helpful? So from the patient perspective, as and when the cancer diagnosis is known to the patient is devastated. Then the burden of making the treatment decision, dealing with complexities of the healthcare system, compounds the anxiety. Some patients are uncomfortable with the responsibility of choosing treatment and would prefer the physician to tell them what to do. Many patients have a sense of inadequacy to understand the terminology, treatment option, and associated long-term ramification. This also holds good for the physician who cannot come down to the patient's level to explain everything in their words. And there are sometimes recommendations of counseling support are not always offered to the patient. It's not available in all institutes. So there are difficulties in getting immediate appointments. Further contributes to the anxiety in decision making. Patients from out of state and particularly out of country, which holds good for our setup also, often experience additional anxiety managing this process long distance. From physician's point of view, the standard process of newly diagnosed prostate cancer is often one-dimensional, processed by the urologist only. And sometimes the physician may also feel challenged to meet demands to stay in the current treatment protocols, as most of us are treating many types of cancer. And some centers have increasingly specialized in to treat only a single type of cancer, but sometimes if it is pertaining to their own speciality, it may lead to narrow-minded tendency. So there is a growing need to coordinate among providers, care providers, and patient, ensuring best possible management to the patient. So hence the multidisciplinary care center has been playing an increasing prominent role in both in community and academic centers. So what can be the benefits of multidisciplinary approach? There is a decreases the time from presentation to treatment, reducing errors, fragmentation, variability among the doctors, ensures application of evidence-based guidelines, improves diagnostics paths, guarantees objective ambiguity, well-balanced proposal for all available therapeutic and observational therapies, guarantees facilities timely access to physical and psycho-emotional rehab programs, helps improve outcomes since the treatment will be uniform, favors enrollment in innovative or experimental protocols, improves education of professional involved in patient care, and increases patients' satisfaction. So the enumerated benefits, are they really true? There was a paper published recently last year, which had 11 questionnaire. They sent to different doctors and they got the response. So they compared two different structures. One is in which patients are seen sequentially by physicians from each discipline. Second was in which patients are seen concurrently by physician from each discipline. More than 90% of providers enjoyed working in multidisciplinary centers. More than 75% preferred seeing in new patients in multidisciplinary as a multidisciplinary team. Additionally, 90% believe that the patient perceived the clinic to be valuable for comprehensive, coordinated, and appropriate care. However, the satisfaction differed between patients and physician. 1/3 of the physician thought the clinics were not an efficient use of their time, but patient uniformly expressed a very high satisfaction with the coordinated care. So this is the distribution of how beneficial it is. More than 50% found it very beneficial or extremely very beneficial from treatment point of view and research point of view, and about 20-25% moderately, and about 10 to 15% were no benefit or slightly beneficial. Now coming to the categorizing in the groups and the treatment. So the group A, sorry. So group A is the multidisciplinary group and group B is the monodisciplinary group. So when it came to low risk, the more in the multidisciplinary group states them as low risk, whereas high risk group was more in the B group than in the A group. But intermediate group was more or less same in both the groups. And coming to treatment, radical prostatectomy was much more with group B, that is monodisciplinary group, than multidisciplinary. But whereas radiotherapy was much more with the multidisciplinary group. And when it comes to active surveillance, again, multidisciplinary was slightly much higher than group B. So I'm going to go through. There is a prostate care initiative in Europe by European School of Oncology, and there I'm just discussing how they have formed their multidisciplinary unit and their protocols. They have three teams. One is core team, that second is non-core team, and they have recommended another non-core team. The core team consists of the prostate cancer unit director, urologist, radiation oncologist, medical oncologist, pathologist, nurse, professional dedicated to data management, documentation representative. Non-core team is imaging specialist, medical physicist, radiation technologist, specialist in palliative care, psychologist, patient advocates, clinical trial coordinator. The recommended non-core group is physiotherapist, sexual therapist, or urologist trained in andrological urology, or certified andrologist, or clinical nurse specialist, and a geriatrician. So how is it formed? For the critical mass, how to see the patients? More than 100 newly registered cases of prostate cancer discussed in the interdisciplinary multi-professional team meeting during or monitored by PSC each year. All immediate or deferred treatments and observational protocol must be carried out under the guidance of unit's medical team. What are the guidelines for treatment? Evidence-based written guidelines used for diagnosis and for the management of prostate at all stages should be clearly identified. The general mandatory requirement: at least one member of each core group should participate in the interdisciplinary and multi-professional meeting. To be in the team, for urologists, there has to be 2 or more urologists specially trained in prostate disease diagnosis and treatment. At least 50 radical prostatectomy per unit should be performed per unit, and spending approximately 50% of their working time in prostate disease. Radiation oncologists, again 2 or more specialized radiation oncologists, specially trained in prostate cancer, radiotherapy, or brachytherapy. At least 50 treatments, radical or adjuvant, per year per prostate cancer unit, delivered either with external radiotherapy or with brachytherapy. Spending approximately 50% or more of their working time in prostate cancer. The medical oncologists, again 1 or 2 medical oncologists either trained in internal medicine, hematology, oncology, specially trained in the treatment of prostate cancer, seeing at least 50 prostate cancer patients per year, spending more than 50% of their time in working in the prostate cancer. Pathologist, 1 or more pathologists in charge of uropathology responsible for prostate disease. Nurses, again 1 or more nurses dedicated to specialized in urology, devoting at least 75% of his or her time working for genitourinary oncology. Data management, 1 or more professional dedicated to data management. Documentation representative, 1 documentation representative for documenting the system for the prostate cancer unit. So there are 3 possibilities which way the clinic can be run. The first possibility is at least 1 clinic per week should be available for newly referred cases of prostate cancer. The clinic can be monodisciplinary. The patient is seen by the urologist or by radiation oncologist or medical oncologist, and professionals are able to offer psychosocial support where available and handed out written information on possible therapeutic and observational options. The case must be again discussed in the interdisciplinary or multidisciplinary team meeting. Second possibility is the multidisciplinary. Patients are seen in sequence by urologist, the radiation oncologist, the medical oncologist in the advanced cases, and handed out written information on possible therapeutic and observational option. The nurse is again available to provide additional information. The cases must be again discussed in the total interdisciplinary and multi-professional team meeting. The third possibility is the clinic can be multidisciplinary. The patient is seen synchronously by urologist, the radiation oncologist, the medical oncologist for advanced cases, and professionals able to offer psychosocial support where available, hand out written information on possible therapeutic observed options. The nurse is again available to provide additional information and support. Again, the case must be discussed in the interdisciplinary meetings. So the success of this team highly depends on the subjectivity of the actors involved in patient care and a structural element which can facilitate the workflow. So there was a survey again why there was an opposition of multidisciplinary clinic. Most response was lack of infrastructure. Second was again cost. Second was insufficient time from the doctors, and third was lack of cost, lack of funds. So thank you all.
Well, thank you, Dr. Shikha. It has been a great deliberation on multidisciplinary team approach. But as things stand in India, we have to understand our Indian systems. A holistic approach is always required because you see, it is always said that if the patient can appreciate what you are saying, that would be the best. However, it will take definitely some time for patients to be able to appreciate all this, and our infrastructure has to grow to that level that all our patients should be able to accept this as the choice of treatment approach. Because so today, if you understand, the practical thing is that patient comes with faith to one person or a second person. So what we have to do is we have to take the patient's faith also into confidence, and the doctor to which he has come should direct this patient to this multidisciplinary team. So that is far from practical as far as current scenario is concerned. But I fully agree with you that this is the need of the day for better patient care. Is such a holistic team of multidisciplinary approach is absolutely essential, and we are inching towards that. And I'm sure your deliberations and the overall scenario which improves the patient care will help our patients. So with these words, I think we should move. Do you have any questions?
So I would like to make a comment. Like I presented the European structure, but I think as in India, our system is a little different. Maybe we can use a little different and maybe a easier method. If not, so many nurses or psychologists may not be there. At least three, the surgeon and the radiation oncologist and the medical oncologist can meet together and take a combined decision. That will be.
So we have to absolutely correct. I think we have to change as far as our socioeconomic structure is concerned and the kind. So what is practical today, I believe, is that when the patient comes to the doctor, he has to see to it that he discusses with the kind of team whatever is practical. So he can discuss with the radiation oncologist or the other kind of as members, as you have said. But our ultimate goal is that patient should get the best.
So
with these words, if there is no question, then I would like to invite Dr. Sajjan Raj Purohit, who is going to have a panel discussion, who is going to invite the panelists. He is actively involved in cancer care, especially the prostate cancers. And he is the head of chemotherapy unit at BLK Hospital. And he is going to conduct this excellent session of case discussion. It is a panel discussion, case-based, and we have various panelists. So with this, I hand over the proceedings to Dr. Sajjan Raj Purohit for the next hour or so. Dr. Sajjan, please.
Thank you, sir, for the kind words of introduction, and thank you, Dr. Chandru, for including me to this important lecture series on how to best manage prostate cancer and how a multidisciplinary team is the need of the hour. And Dr. Shikha also mentioned that the best decisions are taken when all the members are involved into the treatment decisions in such patients. So I'll invite my panelists. So we have very esteemed panelists in today evening's panel discussion. So Dr. Kushal Kalra from Surgeon Hospital Medical Oncologist. Then I have Dr. Harvinder Chauhan and Dr. Safalta and Dr. YPS Rana. He is a surgical oncologist with us, who is also urologist and surgical oncologist. Dr. Sumit Agrawal, who is a radiation oncologist. So we now have a team of urologists, radiation oncologists, medical oncologists, and surgeons. So it's an apt team where we can discuss this case, and I hope that we are able to reach certain points when we discuss this case. So I'll be discussing metastatic hormone-sensitive prostate cancer. Just to take the case along, can we move to the next slide? So the first case is 72-year-old male patient presented with back pain to a spine surgeon. So sometimes patients won't land up directly with the urologist or the medical oncologist. They might go to some other areas, and many times orthopedic surgeons are the first people to have prostate cancer patients. And then they, based upon their findings, refer these patients either to urologist or to an oncologist. The patient had coexisting comorbidities of hypertension, had also undergone a CABG in 2004, though there were no urinary symptoms. The spine X-ray showed lumbar canal stenosis. He underwent actually spinal surgery for the same, and no biopsy or PSA was done. And this is kind of a real life scenario when mostly people would feel that 72-year-old gentleman coming with a lower backache, X-ray is done, and based upon that, surgery is done. Next slide, please. So 2 years later, the patient starts having obstructive LUTs as well as recurrent backache, and then probably after going to 2-3 specialists, lands up with a urologist who on examination finds a hard prostate. PSA is done, it is 86. Bone scan shows 2 hot spots in the lumbar spine. Biopsy is done, Gleason's is 4+4. MRI shows there is no nodal or visceral disease. The urologist starts the Zoladex as well as bicalutamide, and the patient is put on this treatment. Next slide. So patient improves markedly. The PSA does really well. At 8 months, PSA is 1.9, and he develops again urinary symptoms leading to urinary retention. And there's a lot of issues with the catheterization, and the patient has refractory urinary retention and a big prostate. PSMA scan shows there's a lesion in the prostate, L2 and L5 vertebrae there, though the backache is controlled. Next slide. So here is a case which started with a spinal surgery, has been doing very well on the first line treatment what the urologist has offered. So I will first start with the surgeon in our team. So Dr. YPS Rana, if such a patient lands up with you today, so would your management be same or would it be different? How would you treat such patient in today's era? Will it be different from what a fellow urologist would have done, or it would be quite similar to the case? Dr. Rana, you are on mute. You are on mute. Please unmute yourself.
Right. Okay, thank you and good evening all. So this case actually, when I was going through your presentation, the initial presentation was like surgery was done on the basis of some X-ray only, lumbar canal stenosis. The MRI maybe that time could have picked up all those hot lesions. So one miss was the MRI in the beginning. Then second, it is a high risk disease with a PS metastatic 86 4+4. Now, I won't qualify this patient as a oligometastatic. I will definitely at this point in time do the channel TURP. This is a 72 and a high overall CABG was done 2004. So lots other comorbidities. So in the beginning, along with the Zoladex, I would have started either abiraterone or enzalutamide for this patient. So no, just the Zoladex is not sufficient when the metastatic setting upfront is there. So the addition of abiraterone versus enzalutamide upfront in that time, and the bone care by the denosumab should have been upfront. Now, as the patient is landing in retention, then the channel TURP definitely, and radiation also. I'll offer the radiation to the prostate and the spine both. So multi-modality treatment I'll offer this patient.
Okay. So we have our radiation oncology colleagues here. So Dr. Sumit, I would like to take your opinion. The patient came, so patient has now come and seen Dr. YPS Rana, and he's very happy to recommend and forward this patient to you. So what would you do with this patient?
Hi, good evening, everyone. Sir, in this case, probably I would like to go ahead with the radiation therapy to the prostate and also to the metastatic sites, because as we see the data in the recent trials, it qualifies to the low burden disease. So low burden or low metastatic disease has benefit in survival and OS and PFS in the STAMPEDE and the HORE trial, unlike the high burden disease or the high metastatic disease. And I think this after hormone therapy, there is also a reduction in the size of the prostate, which will give us adequate margins with the rectum and the bladder. So with the minimum of toxicity and looking at the survival benefit in this low metastatic setting, I would definitely recommend radiation therapy to the prostate as well as the metastatic lumbar spine sites.
Okay. So I'll come to Dr. Kaushal. Dr. Kaushal, will your approach be different? Would you like that patient to be seen in a multidisciplinary team, and you will say, Dr. Sumit, oh, just wait for some time, let me start some treatment, and then you decide what to do. So how would your approach be different from Dr. Sumit's approach?
Yeah, actually, this is clear-cut is a metastatic disease. So I will go for direct anti-androgen, either abiraterone and enzalutamide. I will not go for these things because it's a metastatic disease. After Zoladex progressed, I will go up front for this thing.
Okay, okay. So Dr. Harvinder, your opinion, sir. Please unmute yourself. Dr. Harvinder, please unmute yourself.
Hello. Am I audible now?
Yes, yes, yes.
Thank you. Good evening to all. Here I would like to comment that patient is already 74 years old with multiple comorbidities and now presented with the lower urinary tract symptoms, that is retention of urine. So definitely, first of all, I would like to address the retention of urine, that is by doing the channel TURP. And already patient is on anti-androgen therapy. So first and foremost thing is to start him on, give him relief from retention of urine, that is by channel TURP. And simultaneously, he can undergo bilateral orchidectomy because he is already going to the operation theater. So bilateral orchidectomy can be.
Yeah, that's a very good point you added. So what about systemic treatment or radiation? So would you be upfront interested in going for radiation, or you would like to change the systemic treatment and then see over time and then add radiation?
Regarding radiation, I will definitely like to wait. If patient is having is symptomatic for bony pains or something, then I would like to add radiation therapy.
Okay, okay. Dr. Safalta, every day I see so many research articles from you. So I like to have that research. Do you have you written some research paper on this?
No, sir.
Okay. So from your vast experience, let us know what would be your take.
So you are pulling my leg, huh? Now, see, as such, there are no randomized trial which has compared surgery versus local radiation to the prostate. But then meta-analysis and retrospective analysis, they have shown that the patients who have received radiation instead of just hormonal treatment or surgery, they have done better. Now here the issue is he is having obstructive symptoms. So for relieving the obstructive symptoms, I'll fully agree with the surgeons that channel TURP can be done just to relieve, because even if you start hormonal treatment, it will take some time. For by that time, you should do some procedure so that at least that will be relieved. Then followed by that, I'll go ahead with the radiation of the prostate. Along with that, I'll start abiraterone or enzalutamide to the patient.
So, but I think this patient has already received 8 months of hormonal therapy, right, sir?
He has received a TABI. He has received
He has
bicular.
not received. Okay, right.
No, he has not
But
received.
Zoladex he has received, right? Continuous
Yes, Zoladex he has received, and we will continue Zoladex.
Okay, so after Zoladex, he'll end up in this urinary retention.
Yes, progression.
Okay, okay.
So what I can gather from all of your discussion, I think very valid points, and so we have reached to kind of a conclusion that yes, channel TURP might be a very good idea, and occlurectomy can also be included. Many times as medical oncologists, we are just I would say hanging on to either GNRH antagonist or an agonist, and we hardly counsel such patients for occlurectomies, and that could be one of the opportunities. If the patient is undergoing a surgery, I think occlurectomy can be offered, which is a very valid and a very, I would say, practical point for the patient. Number two, with a patient who has been doing so well, like the patient has actually done well. 2 years so with back pain also that patient was doing well. So just seeing the biology of the disease, it is very much possible that the kind of disease the patient is having is probably a oligometastatic and slow progressing disease. So especially very important is that we go for a comprehensive genetic assessment for such patients, especially in India, who are beyond 75 years of age, and then on prostate we always have this opinion whether the person is likely to live for 5 years, 10 years. So those components are important. Having said that, a person who has got an oligometastatic disease, where we are going for a local channel TURP, adding radiation at this point in time might be a good idea. In fact, we have some data from a HORAD trial which shows that in oligometastatic disease, and also from some of the arms of Stampede, there is some data which shows that radiation at least improves the PFS. So oligometastatic disease, adding radiation might be a good choice, but yes, again, it comes with additional morbidities, as well as there are high chances of having a lot of urinary complaints which might be there. So these are important, especially with a large prostate of more than 100 grams. So that is one challenge which might be there, but then that can be discussed with the family members. So I would say there's no one who is right, but yes, the patient can be put right away on abiraterone, and we can continue on a GNRH agonist or antagonist, and that can also do well. Addition of radiation in the form of local treatment might improve the progression-free survival of such patients, especially if the patient is otherwise fit. So I think with this, we'll move to the session. Can we go to the next slide, please? So, okay, now just go back. So there's some more questions which I need to get answers. So, so I'll ask this to Safalta. Safalta, your choice of drug, enzalutamide, abiraterone, or epleturamide? Any choice of drugs for you?
As such, the choice is done by the side effect profile of the patient. The patient is having hypertension, he is having CAD, probably he is not having diabetes, right?
Yes.
So I am comfortable using abiraterone in this patient, as well as I am comfortable in using epleturamide, any of the drugs. So, and epleturamide as such is like costly drug, so I'll go ahead with the abiraterone in this patient.
Abiraterone. Cost is the issue. So let's ask Dr. Kaushal also. Dr. Kaushal, your choice of drug with respect to the patient's general condition?
Yeah, I will go for abiraterone because patient is not diabetic. Hypertension is there. So I will go for abiraterone first.
Abiraterone. Okay. So channel TURP and radical. Dr. YPS Rana, any role of radical prostatectomy, especially if the patient is otherwise fit? Any role of radical prostatectomy?
Definitely. With the robot in our hand, in oligometastatic cases, definitely in this kind of scenario, after hormone therapy, there is progression and retention. It's a big prostate. 100 gram is a very big prostate. So the radical prostatectomy definitely is considered in some selected cases when there are no comorbidities, patient is relatively young with this kind of 4+4 Gleason. But the point is, post radical prostatectomy also there will be some positive margins. So the counseling has to be there for the radiation therapy also. Okay. So definitely the counseling has to be there for the additional radiotherapy also. But overall, the urinary symptoms, they are much better relieved. If the surgical expertise is there, then the continence rate is also quite good. So,
okay. So,
sir, I have a point, a little question also.
Yes.
So adding surgery in this scenario probably is a difficult choice for this age group of the patient with so much of comorbidity. And I think with the surgery, after we have seminal vesicle involvement, margin positivity, and other risk factors, then adding one more modality would be more sometime hazardous for the patient, might be. And so probably I think surgical a little we have to think about the surgical, especially the radical prostatectomy. We are okay because this patient needs the URP. Definitely he needs channel to URP, but radical prostatectomy in this setting, we have to see.
No, definitely it's a better choice than the channel TURP actually. But the problem is with the patient morbidity and post CABG.
Okay, so I'll involve Safalta here. Safalta will say, sir, you are pulling my leg, but then I need to pull your leg to, because surgeon is saying I'll do radical prostatectomy. The radiation oncologist is saying I can do radical RT. You are saying I can do radical, whatever rest is left. So if you were to decide, the patient came to you, so what do you choose?
Actually, radical prostatectomy is not indicated in a patient who is 72 years. It is usually indicated in a patient who is young. So...
No, ma'am. Age is not the criteria. Sorry.
Even like multiple guidelines and all, everything is showing that radical prostatectomy, it is like PFS, comparison of the PFS in the patients who are having oligometastatic, then it is 77%, 20% and 3% PFS. So it is like, I will go ahead with the radical radiation, definitive radiation in this patient for this prostate thing. And radical prostatectomy is only indicated when it is young, when the patient is young.
So, okay. So before I come to Dr. Rana, just two more panelists, please. Then I come. You have your last word. The surgeons always have the last word. Dr. Kaushal, what is your opinion in such a patient? Local modality, surgery versus RT.
Yeah, I agree. If channel URP is okay, radical prostatectomy will be difficult. So much comorbidity, CABG is be done and hypertensive. So I will just against.
So you are supporting Sumit. Okay, I just take one more word from. I'm not able to see Dr. Chauhan. I'm not able to see. So
yeah, you're on.
You're there, sir.
Yeah, definitely.
Yeah, please, your words, your take on this.
Radical prostatectomy in oligometastatic diseases can be done nowadays, but in this scenario, this case, 74 years old, already having multiple comorbidities, definitely radical prostatectomy is out of question. There is no option for prostatectomy in this scenario.
So, so the panel is divided. So we have a surgeon who can say that, okay, surgery is possible. I can do it. The patient is fit. Now we have radiation oncologists who can actually say that, okay, radiation is very much feasible. It takes care of oligometastatic disease. So I think these are the real world scenarios where we have these kind of fights into our tumor boards. In fact, I will also give my opinion, though I understand that surgery can be one of the options if we discuss with the patient in detail. But with such a scenario where it is only oligometastatic disease and the patient has got a large volume of disease, sometimes post radiation also you might require additional local control in the form of RT. So that is one challenge which might actually be not very, I would say, with respect to patients' comorbidities, might not be a good thing. But I'll also put Dr. YPS Rana's point now. So this is what I think the panel feels. Dr. Rana, your take upon what the panel feels.
Okay, so actually I disagree with Dr. Safalta here regarding the age. 72 for a radical prostatectomy, it's not very advanced age. And the robotic prostatectomy takes 3 hours. Continence, we are giving 99% continence to our patients. Majority of our patients are diaper free. I am just hesitant in view of his post-CABG and the comorbidity and the lumbar canal stenosis surgery, because this particular patient qualifies otherwise as a oligometastatic. And there is one term known as the problems of sitting prostates, right? This is a huge prostate. This patient is right now in the retention. Even if we do the channel TURP and do the radical radiotherapy also, there will be hematuria, there will be radiation cystitis, and these kind of patients will be requiring multiple hospitalizations and retention of urine and lot many other procedures. So upfront ruling out the option of radical prostatectomy, it's not justified in the today world. And in the lots of literature is coming up with the radical prostatectomy in the oligometastatic setting. But we have to choose our patient carefully. It's not for all the patients. It is for the patient who are young. 72 is relatively young for the CA prostate and the high Gleason score. So 4+4 is a significant high Gleason score here.
Sir, I have one point to add here. So these days, radiation will not give too much of morbidity because we are more and more image guided and we do hypofractionation, and dose to the prostate in this setting, oligometastatic setting, is lesser than the radical setting. And also we don't see any, because such patients come to us with after TURP, we don't see any hospitalization in patient after radiation. And also we more or less it's an eventless radiation therapy. So radiation comorbidity has lowered with our protocols, our bladder protocols, and going image guidance with the image guidance. So I don't see anything related to the radiation morbidity in this case. This is my personal view.
Right.
So I will just pitch in here. I think you all have made very valid points, and there are certain indications where a surgeon especially might feel that, okay, a local control in the form of radical prostatectomy might be good. We have in today's world more data with respect to radiation as a local control for oligometastatic disease compared to surgical data, where there's a lot of retrospective series and there's also meta-analysis. But then if you ask me of the evidence today, evidence is more in favor of local control in the form of a local RT. But yes, if somebody would like to go for a local surgery also, that might be also institutional practice or a surgeon's own choice that I have in my series found that this works better. So we will move on. We'll move on from here. So can we go to the next slide, please? Here, next slide. So we all know that our aim of local treatment is to improve the overall survival, and also we also have to like to have less interventions and delay the systemic treatment as far as possible, and that systemic treatment is chemotherapy. So otherwise patients tolerate oral drugs really well, and I can also vouch that oral drugs are very good and with minimal side effects. Like now we have safer radiation, safer surgeries, we also have safer drugs, and in medical oncologist kitty also. Next slide. So we now know that we have a lot of debates into whether what should be done for such patients. Can we go very radical? Because oligometastatic disease sometimes have a long control, especially if we go for radiation with SBRT and local radiation. Such patients have shown in these phase 3 trials that their 5-year PFS improved from 16% to around 46%. So there was a huge improvement in especially oligometastatic disease in selected patients. So such patients are likely to do better, but then yes, based upon case to case, we should select such patients. Next slide. So with this we already discussed. Can we go to the next slide, please? And this is shown here. We have seen that compared to extensive disease, oligometastatic disease fares much better. And in today's world, a multidisciplinary approach to oligometastatic disease should be better. So if a patient comes to me today with oligometastatic disease, I will not keep the patient only to myself and just keep offering them oral hormonal drugs, keep changing them and not offer them any local. I would definitely be inclined to use local treatments because that has been shown in both systematic reviews as well as in phase 3 data that there's an improvement in progression-free survival. Next slide. Next slide. There's a lot of data here, which so these are all they are all outcomes which are based upon, like Dr. Rana mentioned, there was a multi-institutional analysis of perioperative outcomes of 106 men who underwent radical prostatectomy for distant patients. So overall, this complication rates were very low. So almost 80% patients did very well when these patients were offered radical prostatectomy in good hands. Even 22-month oral survival also was quite impressive. So this was an observation study. Next slide. So the C data also shows that there's impact on the survival with the addition of local treatment. Next slide. Next slide. So we now know that, yeah. So again, this again data from the, can we go to the next slide, please? Next slide. So now this is a phase 3 HORAD data where 432 patients were randomized to either only androgen deprivation therapy or with EBRT. And primary endpoint was overall survival. And 67%, almost 160 patients had actually more than 5 metastases. So this was not even oligometastatic disease. This was only a like 2/3 patients were not oligometastatic. Only 1/3 patients were oligometastatic. Median follow-up was 47 months. Next slide. And when we see the median survival was 45 months versus 43 months, so the median OS was not really improved. Even time to PSA progression was not improved. So, but the only negative thing with this trial was that the only 1/3 of these patients were oligometastatic. So this is the criticism of this trial. But in the subset which was oligometastatic, there was a trend towards increased PFS. So there was no substantial improvement in survival with addition of RT. But probably this trial was not wisely designed. Next slide. This was again a radiotherapy for newly diagnosed oligometastatic prostate cancer. This was a randomized trial, which was, can we go to the next slide? One slide back. So this trial, it was published in 2018, and 2061 men were randomized either to standard of care with or without docetaxel or standard of care with EBRT. So here adding RT improved the failure-free survival with a hazard ratio of 0.76, though OS was not improved. And in high volume disease, there was no benefit. So in selected oligometastatic disease, there appears to be a benefit in the progression-free survival. However, OS survival has not been seen with any of the local treatments in the form of radiation or the surgery. Next slide. So as I mentioned, the patient was with the urologist and underwent a radical prostatectomy, and I can see Dr. Rana really smiling. And it was a P33B. 1 out of 18 nodes were positive, margins were negative, 60% of prostate was involved. So Dr. Rana, now what would you do?
So 1 out of 18 lymph node positive and margins are negative. That's a good thing. So he'll continue with the abiraterone and bisolone, and I'll give radiation to the spine only.
Radiation to spine. Sumit,
yeah.
Would you like to radiate more, or you are happy only radiating the spine?
I think just the spine is good enough. Spine and the lymph nodes. Yeah.
No, sir. I'm asking Sumit. So I can't.
So if this node had been negative, I would have been more than happy to go with this. Will not irradiate probably the prostate, but I think with this nodal disease, we have to cover all the lymphatic channels probably. And in single setting, probably with the hypofractionation because hypofractionation these days is a very good tool in which only with the 15 to 20 sittings we can complete the radiation to the prostate. And probably in this setting only, I will interdigitate and sandwich the SBRT between my radiation.
Okay, Dr. Safalta, your point.
I agree with Dr. Sumit.
Okay, this time you're short and sweet. So, Dr. Kaushal, you are in deep thoughts. What would you like to do?
I will not go for radiation therapy for this prostate, but if yes, if patient is symptomatic, then spine we can go for this thing, radiation, local spine therapy.
Okay.
Local
So
radiation.
if the patient is symptomatic for back, you will be happy to send it to Sumit. Otherwise, you will be happy to continue systemic treatment.
Correct.
I think it's a very valid point. So especially with oligometastatic disease, so do we really suggest such patients to dual local control? So I'll ask Dr. Chauhan. Dr. Chauhan, you are there?
Yeah, I'm there only.
Yeah, I'm not able to see you on the camera. I'm so sorry. That's why I keep on asking you again. So Dr.
Okay.
Chauhan, your point.
Yeah, definitely. I'll refer this patient now to Dr. Sumit for his expertise.
Sumit is so happy. The surgeons and radiation oncologists are very happy. So Sumit, you'll be okay. So my take would again be, see, because again, what are we dealing with? So one local modality has been done. So I feel a bulk of the disease has been removed by radical prostatectomy. Even the nodes which were positive have been removed. So if I were to decide in the board, I would definitely go only for SBRT of the spine and continue systemic treatment. But yes, I respect each of your views. Addition radiation to the local site, especially with hyperfractionation and with expert doctors like Sumit, can be possible. But yes, that would be my choice. So Sumit, would you like to take some different choice for mine?
No, sir. I totally agree with your choice.
Okay.
So sorry to
interrupt. Yes, Survi, you can continue.
So sorry to interrupt, but time's up.
Time's up. Okay. Okay. I think we had discussion on our case, and I would not like to. Okay, just one more slide. Then we'll just wrap this up. Next slide, please. Next slide. So post-surgery course was that patient was doing well, and then there was no additional treatment which was planned, and then again patient had started having some PSA rise, testosterone was in the castrate level, and then no treatment was given except Zoladex. And I think so we'll stop it here. The purpose of this discussion was to discuss among the various panels as to how best to manage such patients and when to incorporate the local treatment and which is the best way for systemic treatment, how to manage an oligometastatic disease to improve the outcome. So I hope that this case for discussion was really useful to all of us, and we had certain learnings, and I thoroughly enjoyed this panel discussion with my esteemed panelists, and I thank each and every one of you for sparing your time for this panel discussion today. And back to the organizers.
Thank you, Surgeon. Thank you for excellent conduct of a panel discussion. So it's really wonderful, and we've discussed the intricacies of management, especially concentrating on the oligometastatic disease, which is less spoken of. Really, thank you, and thank you all the panelists for their views. So, Dr. Anil sir is there?
Yeah. So can you hear me?
Sir, I invite you to just give your expert comments on the same, sir.
Yeah, so I'm really happy that Sajjan has brought out a case that a nice panel discussion could be done. And the only thing which we must appreciate and understand that patient factors. We always happen to discuss about the disease per se, and we in the process tend to forget about the patient and his thoughts about the whole scenario. So a good individualized counseling with the patient is appropriate. And as far as this case is concerned, there are three things. One is the local treatment, for which Dr. Rana has said about this radical prostatectomy, and it has been done to this patient, but radical prostatectomy is not always feasible, especially in a patient who is 75 years of age with comorbidities, and even the patient and families may not be willing to get it done. Most of the times, this is not that you offer them and it is done. So the other better modalities, and nowadays a lot of literature is coming up about cytoreductive prostatectomies. So this is another dimension where you do laser prostate surgery, because it's a 100-gram prostate. You remove 100 grams in totality from inside and offer radiation, as somebody was saying, EBRT, to the rest, and then you can offer the radiation to the spine, as well as chemotherapy continues and hormonal therapy continues. So there are a lot of options which are also coming up. Even in the research, I saw this paper, very nice paper, that after HIFU, also people had done this thing, TURP followed by HIFU and radiation therapy. So there is a scope for more this thing, kind of a treatment which is patient friendly. So if we have very many comorbidities, we can make it more patient friendly. But I fully agree with the panel. The kind of approach we have to take care of the local disease, and the sitting prostate also has to be removed. Plus, we have to take care of the hormonal as well as the chemotherapeutic drugs, and radiation also has a place in overall management of this patient.
Thank you, sir, for your expert comments. So now we'll move on to the next session. So without much ado, I would like to invite Dr. Abhishek Raj, who is a consultant, my colleague at BLK Hospital, to dwell on the genetic testing in prostate cancer, what, when, and whom to test. Dr. Abhishek, please.
Thank you so much, Chandra sir. Thank you, AstraZeneca. So the topic given to me today is HRR mutation testing in prostate cancer. I've been allotted 20 minutes, and I think that should suffice me to be able to cover this topic. It's a topic that is generally to be covered by molecular pathologists. So I'm going to harness my Robbins and Cotran, and let's see how we can go forward. So this is I would need my slides to be shared. Thank you so much. So basically, this is a topic. This is the first topic which is covering the personalized medicine in prostate cancer. With the advent of Triton and the PROFOUND trial, we now know that PARP inhibitors now are an important treatment modality in patients who are metastatic castrate-resistant prostate cancer. And the clinical aspect of it will be discussed by my colleague, Dr. Vikas Goswami, in the next lecture. So I'll be mostly discussing about the patients in which we need to undertake the germline BRCA testing, the germline testing for other HRR genes, and the somatic testing as well. What is the prevalence and how it can be utilized in our clinical practice? What are the fallacies of the testing that is there? And what is the clinical evidence for the testing that is available? Next slide, please. So metastatic prostate cancer, it's a biologically, can you go back to the previous slide? Yeah. So it's a, as with any malignancy, it's a very heterogeneous disease. So what we mean by heterogeneous, that there is not just intratumoral heterogeneity, but there can be heterogeneity in between different patients as well. So it's not like one size fits all disease. So different disease have different molecular profile, and that is what has led the researchers to go about doing this testing of the HRR pathway and how it can be targeted for benefits of the patient. So we can see that these various pathways are at play, whether it is the WNT pathway, PI3K pathway, the androgen receptor pathway, which is the most predominant pathway which is at play in patients who are of metastatic CRPC, and whether it is the cell cycle pathway being controlled by RB1 gene, the cyclin-dependent kinase gene, and whether it is a DNA repair pathway, which is found in various studies to be around 23%. Whether it is germline or whether it is somatic, in various studies, this number varies from as low as 11% to as high as 33 to 35%. So alteration in genes which are directly or indirectly associated with homozygous recombination repair, such as BRCA and ATM, it causes the cell to be deficient in this pathway. So the testing for HRR mutation, both germline and somatic, it not only has an important implication for familial counseling and the screening, but now with the advent of PROFOUND and Triton trial, it has also got a therapeutic implication for patients who are castrate resistant. Next slide, please. So now evidence suggests that this homologous recombination repair, these are an early driver mutation in prostate cancer. Like we know for our FGFR gene in bladder, prostate, or various other pathways. So HRR is also, it is probably mutated early, and probably because of tumor heterogeneity, these mutations tend to accumulate later. So this HRR mutation, it is identified even in localized prostate cancer, and there are clinical studies have assessed that these HRR mutation gene alteration have compared to localized versus metastatic disease. So HRR mutation is also identified in the metastatic. The frequency of HRR mutation in metastatic disease is slightly higher as compared to the localized, and the presence of HRR mutation, it also confers a poorer prognosis, a higher stage. So it has also got a prognostic significance. Can we move on to the next slide, please? So here you can see that these are the various DNA repair alteration, which is seen in metastatic versus localized disease. You can see that if we see that DNA repair in the primary disease, it is only present in the 10%, while in metastatic disease, it is as high as 27%. Next slide, please. So these are some of the guidelines. This is the NCCN guidelines, which tells us the need to consider not only the tumor, but as well as the genetic testing for the HRR mutation, as well as the MSI and MMR deficiency pathway. So for the localized, which is low, very low to unfavorable intermediate, germline testing is recommended only if family history is positive or there is an intraductal or cribriform histology. If it is very high risk or high risk localized prostate cancer, it is recommended. If it is locoregional disease, it is recommended, and in metastatic disease in all patients, it is recommended. If we talk about the tumor HRR testing for a localized disease, it is not recommended. While for metastatic disease, it is recommended upfront by NCCN. In our clinical practice, for a patient who is castrate sensitive, usually we don't recommend patients on PARP inhibitor based therapy. So in my clinical practice, I probably used to do it once the patient has progressed after the treatment for first line treatment for castrate sensitive prostate cancer. Next slide, please. So there is a large retrospective data that is available, and it has found that there is an association between germline mutation in BRCA and aggressive disease phenotype that I was talking to you about earlier. So we see that as the T stage progresses, the percentage of patients having this germline BRCA2 carrier, it is higher. Similarly, with higher Gleason score, again, the percentage of patients having this germline BRCA2 carrier is again higher. Can we go on to the next slide, please? So the introduction of PARP inhibitors for patients with prostate cancer, it will require routine genomic testing. This is slightly old slide. We know that there are studies of TOPAR, Triton, and Profound, which have compared olaparib as compared to your newer hormonal agents like abiraterone and enzalutamide. And in patients who have positive mutations for BRCA2 and ATM, they have done better as compared to the comparator arm, and so it has got a therapeutic value. Can we move on to the next slide, please? So what needs to be tested? Next slide, please. So this is the NCCN guideline. NCCN guidelines says that for HRR mutation testing, genomic testing recommendations are available. Tumor testing recommendations are also available. So all these four, tumor testing, genomic testing, and which genes are to be tested, and germline testing recommendation, all are available for NCCN guidelines. In various other guidelines, there are this area is still an evolving thing, and some guidelines do recommend germline. Some guidelines have recommend the multi-gene panel testing for germline as well as for HRR. Some recommend only a selected selected genetic testing, like only for BRCA2 and ATM. Next slide, please. So what tumor tissue is to be used? It is prostate cancer is a very unique disease that often you are not able to find visceral disease or lymph nodal disease that are easily accessible. So patient who has metastasized or probably he has progressed to metastatic CRPC, often we see that majority of those patients are going to have bone metastasis. And we know the intricacies and the trouble that we face while biopsying a bone. So the most readily accessible sample to us is usually the primary tissue. If the patient has previously been treated for a localized prostate cancer which has progressed, or a de novo prostate cancer, again, probably the most accessible site is the prostate. So If we have an archival tissue present, we can use that. Or if a very accessible metastatic site is present, that can also be biopsy. So in the Triton study, around 89% of the patients were sampled with your archival tissue. But in that study, it was noted that the yield, that the DNA extraction and the quality of DNA that was taken by the pathologist, it was probably higher in patients who underwent biopsy from the metastatic site as compared to the primary site or the archival tissue site. So if available, if we are able to biopsy the freshly metastatic site, well and good. If we are not able to do it, we are able to trace the previous biopsy, that is also good enough. Can we move ahead, please? So these are some of the, there is also a concept of plasma CT, circulating tumor DNA testing. So in both the PROFOUND as well as the Triton study, the plasma ctDNA testing was another endpoint. It was an exploratory endpoint that was analyzed. And as we know, the limitations of plasma ctDNA testing, that if it is positive, well and good, because the shedding of plasma DNA can vary from as low as 1% to as high as 90% based on the tumor, the load of the tumor, and how heterogeneous the tumor is. So, but if it is negative, we cannot be very sure that it is actually negative. There is a high false negative rate. It can vary from as low as 20% to as high as 40%. So plasma ctDNA testing is also available now. Tissue testing, we know the major limitation of tissue testing is the biopsy site, the availability of archival tissue, particularly in a country like India, where a lot of patients have undergone prostate surgery at a local place or something like that. So retrieval of archival tissue can be an issue here. And on an old sample, which has probably not been fixed properly, there can be an issue with DNA extraction and everything. And blood testing can be used for germline mutation, but we know that germline mutation can skip a lot of HRR pathway mutation that are somatic in nature. So we are going to miss probably an additional 15 to 20% of the population, which might benefit with HRR directed pathway. Next slide, please. So this European guidelines, they recommend the molecular testing, it should take place early on and as soon as the patient becomes castrate resistant. So that is what our clinical practice also is, that as soon as the patient becomes castrate resistant, if we have the tissue available, we should test it, because that's the gold standard. If it is not readily accessible, we can probably do a circulating tumor DNA testing, and if that is positive, we can take it that okay, that is positive for our HRR mutation. Next slide, please. So apart from that, we also have now data for immunotherapy coming. We have trial for MSI high patients in which pembrolizumab works. So testing for MSI should also be taken. And apart from that, BRCA1, 2, ATM, PALB2, and check. And in the absence of family or clinical features, the genetic testing might be of low yield. The prevalence of inherited DNA repair gene mutation in men with prostate cancer unselected with family history was found to be 11.8%. Patients who do not have a strong family history, they are also around 12% of the patients do have this DNA repair gene pathway mutation that is positive. Among them, the BRCA2 is the most common, followed by CHEK2 and ATM, and followed by these rarer mutations like BRCA1, PALB2, and RAD51D. Next slide, please. When to test this I have already discussed. Please move ahead. So this is the natural history of prostate cancer, that the patient is coming up with a primary disease followed by adjuvant therapy. Then patient usually has a biochemical recurrence. Then he has a hormonal castrate sensitive disease. Then he eventually develops castrate resistant prostate cancer. And we know that once the patient develops castrate resistant prostate cancer, an average survival of, we are looking at an average survival of 13 to 15 months. So you should incorporate this testing as soon as possible, so that we can utilize our olaparib and rucaparib as early in the treatment modality as possible, because we have seen that the earlier you use this drug, the more effective they are going to be. Next slide, please. So as we have noticed, for any management of any tumor, Here also a multidisciplinary team or coordinated expertise of all the specialities take place. The role of course, the surgeons, the radiation oncologist, interventional radiologist, pathologist needs to be there. Apart from that, a genetic counselor is also required in this scenario. Next slide, please. How to test? Please, next slide. So as we mentioned, for germline testing, blood sample is the most non-invasive method to test the germline mutation testing. If we are doing the tissue testing, it has an advantage of doing both the germline as well as the somatic mutation testing. If because of any logistic issues, the tissue is not available, you can also do a circulating tumor DNA testing. The limitation of blood testing is that it will not be able to detect the somatic mutation, while for the plasma testing, that is the circulating tumor DNA, it can detect some fraction of even the somatic mutation testing. Circulating tumor cell is still an evolving area in prostate cancer. We don't have recommendations for circulating tumor cells in prostate cancer as yet. Next slide, please. So this we have already discussed that what is the pros and cons of doing the tissue testing as well as the plasma testing. We know that the sensitivity is only around 60 to 80%. Next slide, please. So here you can see this is the study for the prevalence of germline mutation in prostate cancer and germline plus somatic mutation. It is not just the BRCA. A lot of clinicians or a lot of physicians who are not well versed with the genetics of prostate cancer, I have often seen that they just prescribe BRCA1 and BRCA2 for prostate cancer. That is not the right approach. Probably you should do a broad-based genetic testing. If your intention is to prescribe for a genetic testing, if you are planning to do a HRR pathway, you should go for both tumor and somatic, for both germline and somatic testing, because you can see that the yield is 8 to 10% higher if we are doing a broad-based tumor plus somatic testing, and based on that we can prescribe therapy. Next slide, please. So this is the summary that we know that prostate cancer is quite molecularly heterogeneous. A lot of pathways are in place, and utilizing the HRR mutation pathway can often not only help us to select the patients who are to be taken for genetic counseling for screening of other BRCA-related cancer or the familial cancers, but it can also help us to give an additional line of therapy. Now with rucaparib and olaparib available in India, some of the patients can benefit with incorporation of HRRM testing in prostate cancer. Thank you so much.
Thank you, Abhishek, for your lucid presentation and how to test and your views on that, and now to clinically imply this testing into a patients. I would like to invite Dr. Vikas Goswami, who is my close friend and is an associate director at Max Super Specialty Hospital, Vaishali. Over to you, Dr. Vikas, regarding clinical implication of HRM in management of prostate cancer.
Thank you, Dr. Chandragouda. Am I audible?
Yes, you are.
So,
Sir, you are on mute.
are my slides visible?
Yeah,
they're visible.
Yes, sir.
So just make it full screen.
Yeah, I'm doing that. Is it okay?
Yes, sir.
Okay, so after the previous presentation where it was stressed upon the fact that we do need to modify our practice in terms of widening our scope for doing HRR testing. This presentation is more about how much difference does it make if we incorporate PARP inhibitors in the relevant subset of patients. So just a second. So as you can see, Globocon data, we are very well aware of the fact that prostate cancer is not uncommon. In India, it is 16th in terms of incidence. And once a patient steps on the escalator of CRPC, then options remains poor. And just a second. Somehow I can't move my slides. Just a second, please. Yeah. So CRPC remains common, and up to 30% of the CRPC patients have some element of HRR gene combination. This has been studied in various studies. So with this background came the PROFOUND study. This was a phase 3 randomized study where the effect of olaparib was evaluated in a subset of patients who had first requirement was qualifying for HRR mutation in the tumor tissue. This was requirement number 1. And requirement number 2 was they needed to have radiographic progression on either abiraterone or enzalutamide. And the ECOG performance status required was 0 to 2. So, of course, no prior therapy with PARP inhibitor or any DNA damaging cytotoxic chemotherapy, especially the platinums, was there. So they were further divided into cohort A and cohort B. So cohort A had the subset which had BRCA1/2 or ATM gene. So these three are the most common culprits for and most common targets for PARP inhibitors. And cohort B had other genes which were included in the HRR testing. And again, there was a 2:1 randomization with olaparib versus physician choice treatment. And there was a crossover allowed. And the primary endpoint was progression-free survival, especially in cohort A. The secondary endpoints were ORR and PFS in cohort A plus B, and overall survival in cohort A alone, and safety and tolerability. So as you can see, cohort A had BRCA1, 2, and ATM. Cohort B had the other 15 gene panel genes included, which include BARD, BRIP, CDK, CHEK, PALB2, RAD. So that's how the differentiation in terms of genes was. So the results, Lynparza, that is olaparib, significantly improved PFS in patients with alteration in BRCA1, BRCA2, ATM. That was the cohort A, and numerically there was a hazard ratio benefit of 0.34 favoring the olaparib, and this was statistically significant. In terms of absolute values, there was almost doubling. The PFS jumped from 3.55 months to 7.39 months, and at a 12-month median, almost 1/3, that is 28.11 patients were on olaparib as against 9.40% patients who were on the physician's choice treatment. The benefit was seen across all subgroups, though the study PROFOUND was not powered to demonstrate differences in the subset. So the thing that caught my attention was previous taxanes exposure. As you can see, the circle is significantly towards the left versus no previous taxane exposure, where the confidence interval is touching the unity. So though this is not powered to analyze the subset of this kind, but still it makes one thinks that where should you place olaparib? In terms of response rates, 33% of the patients had objective response rate as against 2.3% of the patients. So other other were the pain control measures and all. So they again benefited olaparib. Subsequent slides will kind of reiterate the benefit of olaparib across various secondary endpoints. So here the slide is showing a hazard ratio 0.44 in favor of olaparib for the pain-free interval, and similarly overall survival. the benefit 0.6 hazard ratio was 0.69 in favor of olaparib. And as Abhishek showed in the previous presentation, once there is a CRPC, average survival is 13 to 14 months. So if one can think and imagine how much one is adding by adding olaparib, the number is 19.1 months versus 14.7 months. So roughly 5 months of addition if you add olaparib in terms of overall survival, and the number was significant. Again, one may say that crossover was there, but even crossover adjusted figures were showing benefit in terms of overall survival in terms of for olaparib as against physician choice. The hazard ratio was 0.42 when the crossover adjustment was done. Again, the benefit was seen across all subgroups of patients in terms of overall survival. And if you talk about other parameters, that is PSA fall and CTC. CTC means circulating tumor cells conversion. Here again, olaparib was showing benefit across various percentages. It was way ahead in terms of PSA fall and CTC conversions as against physician choice. If we take the whole cohort, that means that the 3 genes, BRCA1, 2, ATM, and the other 15 genes, then again the benefit was there. So reiterating the point that not only should, as Abhishek was mentioning, it's not just about BRCA1, 2, it's about the other genes as well. And if you include that, the cohort is bigger by another 8 to 10%. So there was a median PFS benefit jumped from 3.52 months to 5.82 months in favor of olaparib for the group at large. And again, the benefit was seen across all subgroups, especially previous taxanes exposure did better than no previous taxanes exposure, and response rates also were 1 in 5. 21% patients responded as against 5% patients. And again, another way was pain inventory. This slide kind of shows the olaparib benefit for pain in terms of the cohort A, and similarly so the fact is that olaparib, the study which kind of reiterates the point, is that across all subgroups, irrespective of previous exposure, if we have a patient who is falling into some kind of gene, as per the HRR benefit, HRR gene panel showed olaparib benefit against others. So this slide basically tries to portray the absolute benefit, though again I must say that it is very difficult to judge individual gene benefit, but still whatever data we have as per the exploratory analysis, we can see the maximum benefit is seen in BRCA2. So between BRCA1 and BRCA2, BRCA2 was the one which showed which was more frequent, and the benefit was there. Similarly, other gene graphs we can see are shown. Other common genes are RAD51B, RAD51B, and RAD54L. So again, irrespective of the cohorts, the benefit was seen across all subgroups, and not just the benefit in terms of response rates, progression-free survival, overall survival, and pain, but very, very importantly, quality of life indicators. Olaparib being an oral medicine, the patient has a significantly better quality of life indicators assessed as here in the form of FACT-P total scoring. So here again, olaparib was superior to the physician's choice. And the point which I was mentioning, irrespective of prior taxanes or no prior taxanes, the benefit is there. However, the hazard ratio, as you can see, for the cohort A for prior taxane exposure was 0.28, and no prior taxane exposure was 0.55. Similarly, in the entire cohort, no prior taxane exposure 0.77 and prior taxane exposure 0.39. Similar kind of results for overall survival, where the benefit, irrespective of taxanes or no toxins, was there. And in terms of side effect efficacy, we have used this drug in breast, pancreas, ovary. So we are very well versed with it. And the side effect profile in this study was in sync with other trials which we have used. And the most common adverse effects were anemia, nausea, and fatigue. So with that, I conclude my presentation. Open to questions.
Thank you, Dr. Vikas, for an excellent presentation of clinical usage of olaparib, which scenario that you use, and the exact advantage of that, the highlighting the fact. So that was really good. If I ask you one question, where exactly you fit in this, in the metastatic CRPC?
I am very clear as of now. One, I do HRR testing at baseline for all my patients. However, olaparib for me comes number 3. So 1 and 2 can be tablets followed by docetaxel, or docetaxel followed by tablets. So again, it is my practice. You asked me about my practice. I would say tablets followed by chemotherapy, docetaxel followed by olaparib followed by cabazitaxel. Now others may disagree, but my reason for choosing olaparib after docetaxel and prior to cabazitaxel is simply giving patient a chemotherapy-free index if the patient falls in that group.
Very well said. Thank you, Dr. Vikas.
Thank you.
So I'll move on to our next session. That's the last session of our day, and I'll welcome Dr. Rajat Shah, who's Associate Director, my senior at Rajiv Gandhi, to deliver the next panel, and he'll be moderating the panel discussion of what has been discussed till now. So the genetic testing in prostate cancer and management of mCRPC. So Rajat Shah is as I said, my senior and a very great academician. And over to you, Dr. Rajat.
Thank you, Dr. Chandru, for the kind introduction. And was going through this prostate cancer program, and it is pretty well designed. And we started with a very enlightening talk on the multidisciplinary management of prostate. So that was very interesting, and good panel discussion by Dr. Sajjan, and my job made a little easier by Dr. Abhishek Raj and Dr. Vikas. Can we have the organizers? I think so. They want to kind of flash a question. I will be sharing my own screen. So I have made some changes. So I'll be sharing my own screen. Ekta ji, so you can. But there is a question, kind of a polling question, which is there.
Yes, sir. Yes, sir. Supporting, please.
Can you flash that?
Yes, sir.
So the organizers here have actually kind of designed a few questions, and we would like to kind of have a consensus amongst our expert panels on these questions. So the question which is in front of us is, in what proportion of patients would you go for genetic testing? So after talks by Dr. Abhishek Raj and Dr. Vikas, in what proportion of patients would you go for genetic testing? Less than 10%, 10 to 30, 30 to 50, or more than 50%? So I think so we all can kind of access this. Can we access this on our?
Yes, sir. Yes, sir, we can.
Yeah. So I encourage all the participants to kind of participate in this online poll and submit the answers. We'll give maybe 10-15 seconds more, and then we can proceed ahead. In the meantime, I would like to invite our esteemed panelists. For today, we have Dr. Gopal Sharma. He's the Director of Medical Oncology at Max Hospital, Vaishali. Dr. Gopal is there.
Hi, Rajat. Yeah.
Dr. Pankaj Goel, hi. Dr. Pankaj Goel, Senior Consultant, Medical Oncology at Rajiv Gandhi Cancer Institute, Rohini. I can see him very well. Dr. Puneet Aluwalia is a principal consultant and urology at Max Hospital, Vaishali and Saket. Dr. Puneet is our urologist on board. Dr. Deepika Chauhan is a senior consultant in radiation oncology at Shanti Mukund Hospital, and she's the radiation oncologist on board. And Dr. Wasim Abbas is there. He's a senior consultant in medical oncology at Max Shalimar Bagh. So we have our quorum is complete. We have got 3 medical oncologists, a radiation oncologist, and a urologist on our discussion. So I hope everyone has completed the online polling. So I'll just share my screen and just try to take the discussion forward. So the panel discussion in the next 15 to 20 minutes would be focusing on the genetic testing in prostate cancer and the management of metastatic CRPC. Sajjan has already discussed the castrate-sensitive prostate cancer. So let us just see. To begin with, Dr. Puneet, you're on board?
Yeah, Dr.
Yeah, Dr. Puneet. So at what point does a prostate cancer patient leave your shelter?
So,
patient from CRPC.
So you want a definition of CRPC, or you want what my practice is? So basically, to answer your first question is, once the I don't give adjuvant therapy to my patients. If the patient requires adjuvant treatment after surgery, I basically deal with patients who are fit for surgery. If the patient requires adjuvant therapy after surgery, based on different criteria of Gleason scores, surgical margins, lymph nodes. So I involve a medical oncologist at that very point, or a radiation oncologist if lymph nodes are not involved. Basically, it's the localized, locally advanced thing. So to answer your second one, CRPC, basically I consider it as a disease state with castrate level of testosterone, with either a biochemical progression of 3 consecutive rises at least 1 week apart, with a 50% rise at 2 occasions above the nadir, and level of 2 nanogram, PSA more than 2 nanogram, or a radiological progression in which there is appearance of 2 bone lesions, new bone lesions, or a soft tissue lesion based on RECIST criteria.
Dr. Deepika, generally in our practice, do we resort to a PSMA PET scan all the time, or do we kind of do some bone scans also, or what is your practice?
Hello, Dr. Rajat. Yeah, actually it depends upon the center. So we have the facility of PSMA PET. So we are always comfortable in prescribing a PSMA PET. Obviously for centers who do not have access to PSMA PET, then bone density and a simple PET might do.
Okay. And
so,
suppose
Dr. Rajat, can I add a point in this?
Yes.
So not for these patients who are already presenting in metastatic. If a patient comes to me with a very low risk disease, in those patients, if he has a bone scan, even though we have a facility of PET-CT, we accept a bone scan in that. So guidelines as of now don't ask for a PSMA PET-CT in all the patients. Yes, for metastatic scenario, the setting is different.
Yeah. So definitely in a low risk case, just for probably getting a fitness for surgery and all, a bone scan may be sufficient. But the purview of my discussion is a metastatic castrate-resistant prostate cancer, and that is where probably, yes, if we have the facility, we should always go for a PSMA PET scan to find out the radiological progression or not. So fair enough. So we all know that the prostate cancer kind of has a very long indolent phase, a preclinical phase, an asymptomatic phase, and then proceeds to symptomatic, and then goes into castrate resistant. So it's a long disease course. So we all have seen patients in almost all the phases. So definitely a lot of drugs have come into the picture after the after the Stampede trial and all. So we have started using docetaxel or abiraterone in the castrate-sensitive population also. So, Dr. Gopal, have you started using docetaxel or abiraterone in high-risk sensitive prostate cancer?
Yeah, Dr. Rajat, we are routinely we are giving in all high-risk patient. If there is good performance status, then docetaxel plus prednisolone. If the PS is not good, in that case, abiraterone plus prednisolone. So we are giving in all high-risk cases, all high-risk cases. Yeah.
Okay. So now moving on to a very specific metastatic CRPC. So Dr. Pankaj, what is the preferred drug of choice for first-line metastatic CRPC? What all factors do you take into consideration? Whether you use hormone, whether you use chemo, or right from the word go, how do we decide this dilemma?
So various factors have to be taken into consideration. One is the performance status, then underlying comorbidities, then we have to see the volume load. What is the disease volume load? So testosterone suppression goes without saying as the baseline key. Every patient has to undergo that. Whether it's surgical or medical is a different issue, but anyway, whatever be the type of suppression you're giving, you have to give it. And then if the patient's volume load is high, performance status is maintained, I think most of us will switch over to docetaxel, because high volume load and good PPS state of go to dosi. If the volume load is not high, say few metastases here there, then I think we are comfortable with abiraterone. Can use enzalutamide as well, but the general practice and most of the experience has been with abiraterone. So it's basically either of these two. Whether we give abiraterone, low volume, few bony mets, high volume, big nodes and above the diaphragm disease, then we go for docetaxel first time.
Correct. So Dr. Wasim, you also agree with the fact if there are a lot of quantum of visceral diseases more and all, you would prefer to give docetaxel upfront rather than rely on the hormonal agents?
Yeah, I think it depends apart. We are talking about metastatic first line metastatic CRPC, right?
Yes.
It depends what patient has received actually, what were the previous therapies and fitness actually. But yeah, talking about like if patient has not received anything, then definitely I think hormonal agents are I think good idea actually. I think the results are same. I don't think docetaxel adds any benefit over the abiraterone or enzalutamide.
Right. So enzalutamide, are you using enzalutamide also, or are you still comfortable with abiraterone?
Yeah, we have been
anything to choose between the two?
No, I don't think there is nothing to choose between.
Correct. So essentially, all the studies and all the sequential regimen have told that basically enzalutamide and abiraterone fare almost equally. There is no major difference in the. Yes, we definitely have more clinical experience with abiraterone because it came probably 2 or 3 years before. So yes, this was one of the earliest trial which catapulted docetaxel into the mainstream. This was versus mitoxantrone, so very ancient trial at this point of time. And these are the various trials of abiraterone and enzalutamide again in the metastatic first line CRPC. So definitely there is very little to kind of decide between abiraterone and enzalutamide. I would say if the patient has some heart issues or is a diabetic to begin with, probably we are okay in starting enzalutamide upfront, because abiraterone will require steroids. Either DEXA or Visolone should be given with abiraterone. So this is a very crowded picture of metastatic CRPC taken from our NCCN guidelines. We have options, and some of the options are not available to us. We don't have Sipuleucel-T, we don't have RAD 223. Dr. Pankaj, are we using the lutetium therapy? Means I'm actually jumping the. I will not.
Please repeat the question.
Are we using lutetium therapy for?
No, sir. Practically, no. We are not using lutetium. Okay. Hardly we have any patient which require lutetium if the patient has exhausted most of the therapies and still pain is a major issue. Otherwise, usually no.
Dr. Deepika, any thoughts on lutetium therapy?
That's what, like Dr. Pankaj said, if most of the modalities are exhausted and patient is in severe pain, then it is definitely a good molecule to use, but we have limited availability. We have other radiopharmaceuticals also, like radium-223 and other beta emitters, strontium and all. But the availability is the issue.
Okay, okay. So the point in question is, suppose the symptomatic bony metastasis, and but there are many metastases. So will the panel go for, and patient, for discussion sake, patient has exhausted abiraterone, enzalutamide, and docetaxel. Will the panel go for radiation therapy to the painful bony sites, or whether the panel will decide for the lutetium therapy? Dr. Wasim. Or Dr.
Yeah, can I comment? I think with new data emerging.
Yeah, Dr. Wasim, we are here.
Yeah, I think new data emerging, definitely we would love to see like mutations go for NGS, and I think as discussed by previous speakers, HRR and BRCA mutations.
Okay, fair. So now you have already told the keyword here, HRR mutations. So what percentage of our patients receive next generation hormonal agents like enzalutamide and abiraterone in the first line metastatic CRPC? I think so. It would be 100% in our cases. We are all using these agents nowadays. We don't have the other agents also, like apalutamide and all have not yet come, but probably will come down the line. So now moving on to the drug of choice for patients of second line setting. Now, once you have exhausted the first line, probably abiraterone or enzalutamide, definitely we generally switch gears and go to the chemotherapy. Am I right, Dr. Pankaj?
Yes,
if
sir.
Suppose we are using the hormonal line of treatment for the first line and the patient progresses, then we counsel the patient for chemotherapy. Any thoughts? Has Dr. Wasim, have you used one hormone after the other? Suppose the patient is maintaining a good general condition. He has somehow failed abiraterone. His PSA is rising, but he's not that symptomatic, or he's not having visceral crisis. So will you prefer to use enzalutamide after abiraterone?
Yeah, definitely. If it is a definitely, it qualifies for a progression, resist progression or persist progression or PSMA progression. Definitely, I would change. I will not wait.
Definitely, you will change. But will you change to a chemo, or will you change to another hormone? Means another line of hormone.
See, we don't have much. We have a data that states that definitely we can change, but definitely standard of care will be chemotherapy.
Yeah. Okay. So definitely, again, here also we can choose either of the drugs, and in whichever sequence, all the sequences are correct, and none of the sequences have showed a very superior advantage over the other. So now coming to cabazitaxel, yes, this is also one of the drugs which is approved for metastatic prostate cancer post docetaxel and post abiraterone. So our experiences with cabazitaxel, Dr. Gopal, you're there? Dr. Gopal doesn't seem to be there. Dr. Pankaj, your experiences with cabazitaxel, how is it? How does it fare? Means, do the patients have a lot of neutropenia, or is it difficult to tolerate down the line?
Honestly speaking, there are very less number of patients who will actually go to Cabazi, because before Cabazi we have 3 lines of treatment at least. We are having abiraterone, we are having enzalutamide, we are having docetaxel. So usually the performance status is not that much retained that we put these patients on cabazitaxel in 4th line. So that way there will be very less patients who will be like, we will be confident to put them on full dose of cabazitaxel. So that way not a very good option.
And Dr. Wasim, you agree? Means cabazitaxel is difficult a drug to try. It may be a good drug, but it's difficult by the virtue that
Right. Really, cabazitaxel is a great drug, and I agree. You have to see like how patient tolerates. What is the dose actually? If you can give a reduced doses and patient tolerates well, I think it's a great drug. And there's a data of a low dose cabazitaxel as well, and that has also served well probably.
Yes. Then there is a data. We can reduce the dose to 15 to 20 milligram per meter square rather than the standard 25 milligram label, which is there. So we have already discussed the ideal drug sequencing pattern. It can be hormone followed by chemo followed by hormone, or hormone chemo followed by hormone. All the things are correct. And as Dr. Pankaj had pointed out, there are various parameters to decide on the sequence of the drugs. The PSA doubling time is there, whether the patient has symptomatic or asymptomatic disease to begin with. Generally, in our clinical practice for asymptomatic disease, we generally choose a hormonal agent first. Whether, as Dr. Wasim had also pointed out, it all depends on whether he has received any previous chemo or hormone in the castrate sensitive part of his treatment. That also decides. And on radiographic parameters, we have got high volume or low volume disease, presence of any visceral disease. And now let's come to what are the biomarkers. So just a quick polling, as our polling question was there, Dr. Deepika, generally in after hearing these talks, generally you would prefer to do the HRR or the BRCA testing at initial presentation when the patient comes to you in your clinic, or down the line when the patient becomes metastatic CRPC? When would you like to do the HRR gene panel testing?
So to be frank, generally patients are, whenever I see the patient, it is already advised by my medical onco colleagues. So I have seen patients which have already got these testings done. So for my management, these things are not, they are not directly having any impact. So that's it.
So Dr. Pankaj, upfront HRR karayenge ki we do it later when the patient becomes CRP?
Sir, I'm a bit selective in getting these tests done. Usually I do not ask for this upfront, because my idea is that you have more of information, you have more of confusion. Not you, but the patient. Patient will be Googling out and the patient will come up with some drugs. Sir, I think this will work better. And so you will have to explain them first line, second line and all that. And second most important thing is I have to analyze whether the patient can really afford the treatment if it turns out to be positive. So if the patient cannot afford, there's no point doing a test and telling, okay, this is a test positive and you cannot afford it. So preferably I do not do it in first line, I do it in the second line.
So Dr. Wasim, any biological rationale whether you would like to do the test at initial presentation or whether you would like to do the test later on? By any biological rationale is there?
Yeah, that's what, as discussed by previous speaker, like when we do on a subsequent biopsy, the genomic alterations are more actually on subsequent biopsies. And again, like when you want to do on a tissue, suppose you do you have a biopsy, you have, and question is like after 2 years that tissue will not be viable actually. And I have done a couple of patients where they couldn't get a DNA actually. That's very tough question actually. And suppose after 2 years patient is having bony mets, so how you will do HRR on a tissue which is like couple of years old again, or NGS on a couple of years old? Actually, so many questions really speaking. And now if you see there's a data again which is coming of olaparib plus abiraterone, that data is also out and it is quite an interesting data. So one may consider doing these HRR and BRCA1 and BRCA2 upfront actually. And if you need to know actually whether patient is BRCA positive, and not only for a treatment purposes, but for a screening purposes as well.
Okay, so
in a family as well.
Yeah, you're moving to the genetic counseling part. So definitely it yields information on genetic counseling. Just correct me if I'm wrong, but as the patient progresses during his prostate cancer treatment, the HRR gene testing is the frequency of the HRR increases, it gets enriched. So data has shown if we do, I think so we have the data here. There is somewhere, I will just show you. So if it is done in the primary tumor, about 27.2% patients have some alterations in the HRR gene. And subsequently down the line, if we do the testing in suppose metastatic tumors and in the CRPC, so it gets enriched. It gets enriched by around 4% to 5%. So yes, there is a logic of doing the HRR panel. if we do it upfront, we are not changing the management. Apart from genetic counseling, yes, we are definitely doing genetic counseling, but apart from that, it is not changing the management in the initial 2 to 3 years or 4 years of the life of a prostate cancer patient, isn't it? So down the line, yes, when the patient becomes MCRPC, then also maybe about for 2 years, 3 years, we are able to drag the patient along. Yes, there is a difficulty in obtaining a biopsy from a bony site. So that is a very big question. So Dr. Abhishek Raj had given the option of doing a circulating tumor DNA testing for HRR. So, Dr. Pankaj, are you comfortable with a ctDNA or a liquid biopsy kind of for HRR panel testing?
No, sir. Actually, we are not very happy and confident about the results of this. We actually need a tissue biopsy.
Yes,
preferably need a tissue biopsy.
Dr. Rajat, can I ask a question here before you go forward?
Please.
Yeah. So regarding the germline testing, upfront germline testing, I just wanted to know your opinion as a medical oncologist or the panelists here or anyone else if you want to speak. So can you go one slide back? Yeah, this one. So if you see the first section through the cancer stage, so metastatic, agreed, metastatic you have to do. So I get most of the patients which are localized. So in this context, you can say high risk localized prostate cancer. Now, NCCN says you have to do germline testing. It's recommended for all high risk localized prostate cancer. So do you agree with this or you don't? Because if you see EAU guidelines, they don't say just the high risk prostate cancer. They say high risk prostate cancer with a family history of prostate cancer less than 60 years. So suppose I get a patient who is medically fit to be operated. We ask him, we give him an option of surgery. He's 70 years or something. He has more than 5 years of life expectancy, but he comes under the category of high risk localized prostate cancer. I think it'll be an overkill to ask him to go for germline testing at that point of time. So do you agree with this, or you think that all the high risk localized prostate cancer should undergo irrespective of the family history?
If we, Dr. Wasim, if we follow this algorithm, I think so 80 to 90% of our patients at first presentation will be eligible for germline testing.
Yes.
Dr. Wasim, would you still do it if we follow this guideline?
Yeah, completely. See, what they have done actually, when they reviewed this data, they saw patients who have high Gleason score 9, who are young, early presentation, and who have a locally
young is okay. Young is okay. I'm asking. It doesn't say young.
Who have a Gleason score of like kind of very high, and they have found the incidence is very high. Actually, they have found of BRCA2 mutations, and not only in young, actually in elderly as well, who have a very high Gleason score. So I know it is an evolving data, but 10% of BRCA
because
mutation
EAU guidelines is very clear on this. It doesn't say high risk as a blanket. It says high risk with a family history less than 60 years. Or for that matter, even a low risk prostate cancer or any prostate cancer with multiple first degree family relatives with a history of prostate cancer or high risk germline mutations of other familial cancers. So in that is fine. But just this was my doubt actually. So I
completely agree. They are not always that liberal with guidelines, probably, actually. What I believe, that's my take. But 10% incidence of in elderly, even I don't know the age actually, but they have mentioned early, it is like 8-10%, and that's kind of very high.
So yes, if we follow the NCCN guidelines to the letter, then
because most of the patients will come in that after 60 years of age. So if we go by this, every patient we should ask for.
That's a very challenging for you as well, probably.
So okay, so Dr. Pankaj has already said that he's not very comfortable with ctDNA evaluation of HRR. We all are very comfortable with the somatic tumor testing of the HRR panel testing. Correct. So this is the general frequency of the BRCA and other gene alterations, the HRR gene alterations in the entire cohort of prostate cancer patients. So it amounts to approximately 25%. So BRCA is approximately around say 17 to 18%, and rest about 10% is the other HRR gene mutation testing. So that's a pretty good number. And we have, I would admit that we have been ignoring this approximately 25% of patients in the past whatever years we have been practicing, and we have not been actually addressing approximately 25% of our patients. We do ACT testing for 2% frequency. We don't do HRR testing for 25% frequency. So we should do it, definitely. So we had an extensive discussion on at what stage of the patient journey would you recommend a HRR mutation testing. So at diagnosis or at metastasis, the house is divided. Dr. Wasim is saying at diagnosis, Dr. Pankaj is saying probably at metastasis. And definitely the data is evolving. And my take is that at metastasis, probably the tissue is more enriched. And if we are able to get a good biopsy, I would prefer to do it at metastasis.
Yeah, can I sorry, interrupt you? From where you will get a biopsy? I have two patients which have bony only mets, and I cannot get a biopsy for HRR. And two patients actually last month, and subsequently I did send for obviously for HRR, and they said the tissue is not viable. Actually, they did send both the blocks back. So what I do now actually? I always think I should have done long back till the tissue was viable actually.
So let me ask you, had it been a breast cancer patient, you would have definitely changed the bone and done the bone biopsy, because in breast cancer we are trained to do a repeat biopsy at progression.
Completely
but in prostate
agree.
cancer, our mindset is still not changed so much. We still rely on the first Gleason score, the first everything, and then we continue our manage for the next 5-6 years, isn't it?
And again, after decalcification, how much will be the viability of doing HRR? That's again a next question.
Yeah, so that is definitely worth looking. Dr. Pankaj, any changes in the NGS or the DNA quality after we decalcify the bone? Any idea? So
Sir, I am not sure whether there will be major changes in the DNA. In the receptor status, okay, ISC markers, yes, but I am not very sure about this. I think a pathologist will be the best person to comment, but I think that that quality will be still maintained.
So I think so our mindset has to change a little. We have to be more aggressive in managing our prostate cancer patients. We generally do a PSA and then proceed ahead and change our treatment based on that. But here, these data is prompting us to probably do a biopsy, probably a bone biopsy, even if it is required to get the HRR gene testing.
Dr. Rajat?
Yeah, Dr.
Sorry for interrupting. I would like to point towards an important observation. So these patients, sometimes when we are planning for symptomatic bony metastasis, what we see is at the site of pain, there is significant osteoporosis. So these patients can be osteopenic as well. So to do a simple test like bone density is very important, because most of these patients are elderly gentlemen, or probably because of multiple hormonal therapy, they do become osteoporotic.
Agreed.
All the pain is not because of the sclerotic deposits. Sometimes they can be osteopenic as well.
Agreed. So that is a very important point which has been brought out by Dr. Deepika, that almost I would say 80 to 90% of our patients of prostate cancer would be having a bad T-score on bone densitometry, and which we generally do not, which we generally ignore during our entire treatment. We should definitely from time to time do a bone densitometry test also.
Rajat?
Yes, Dr. Gopal,
Yeah,
you're back.
I agree with Dr. Wasim, but because in patient with bone only disease, the bone biopsy is always challenging, even in breast cancer also. So important point is not pathologist point of view. Radiological intervention, basically the skill of the person who is doing bone biopsy and the yield of tissue is very important. And most of the elderly patients are not willing for repeat biopsy.
Correct. So first we need to be convinced, and then we need to kind of convince. So it is a steep learning curve in prostate cancer. In breast cancer, we
Yes,
have
yes,
been
yes.
able to overcome this barrier. In lung cancer, we have been able to
So,
overcome this
so
barrier.
doing a baseline HRR testing is not a bad idea, if at least that is available with us.
Okay, good, good. So, so this is what we are kind of saying, that sourcing sample material from the biopsy or surgery could be a challenge. That is what Dr. Gopal has also pointed out. So doing HRR mutation testing at initial presentation also might be one of the good ideas, which Dr. Wasim and Dr. Gopal are suggesting. So and this is what is pointed out in this diagram also, that in our clinical practice, we are using the archived tissue for testing the HRR panel. Approximately 90% of the consultants are using archived tissue, and only 10% newly diagnosed, newly collected, or a newly biopsied sample is taken. So that is, yes. So archived tissue is generally used, and so we may either do it upfront or we may do it later when the patient progresses.
So my apologies. You need to conclude your panel discussion. Just 2 minutes left. Yeah, sure. Thank you. Thank you, ma'am.
So Dr. Vikas has already discussed the PROFOUND trial, and here also basically archived tissue is has been one of the sources of testing this HRR testing. So the preferred algorithm for testing is definitely the tissue. And if suppose by chance the tissue is not sufficient or in a bad quality, then we have the option of doing a plasma ctDNA. We are yet to gather confidence, but yes, down the line we may definitely gather confidence in that. So so we have discussed the local barriers to widespread and routine adoption of the gene panel testing, and how best we can overcome these barriers. So we can either do these tests at initial presentation, we can preserve the tissue better, and maybe use that tissue for later on. And now the final question to Dr. Wasim and to Dr. Gopal and Dr. Pankaj: what is your opinion about the benefit of PARP inhibitors, and how will you place them in your practice? So Dr. Wasim, to start with, will you suppose the patient is HRR mutated, will you reserve olaparib after you have used the standard enzalutamide, abiraterone, and docetaxel, or would you kind of introduce it earlier?
Yeah, in metastatic CRPC, definitely I would use them after the standard of care therapies, after they definitely dosi, abiraterone, and cabazitaxel.
And Dr. Gopal?
I agree with Wasim. Yeah, I agree with Wasim. And the benefit is already Dr. Vikas Goswami and Dr. Abhishek have highlighted 66% risk reduction in death and progression. So I would like to use after first line of treatment.
After first line, so you would
after docetaxel or after abiraterone. Yeah.
After whatever first line you have given, you would probably switch over to an olaparib in the second line. Dr. Pankaj, would you
for me, it would be
in the second line or third, fourth line ke baad denge aap?
Sir, for me, it would be using chemotherapy docetaxel and using one of these abiraterone or enzalutamide, and third line would be this. So first line, second line is chemo and tablets, third line comes olaparib.
So you agree more with Dr. Wasim that you will be probably using it later on once you have utilized chemotherapy and one of the hormones.
Before cabazitaxel.
Before cabazitaxel.
Yeah,
cabazitaxel
and Dr. Rajat,
yes.
This also depend upon the various factors like performance status of the patient and whether patient is waiting for chemotherapy or not. And so if we have used first line docetaxel and if patient is willing for a targeted drug, then either abiraterone or PARP inhibitor is a choice.
Correct. So just to end the discussion, we have do we have consensus on the HRR testing? We can use either any of the regional metastasis or distant metastatic patients should be taken up for HRR panel testing. All high-risk prostate cancer patients, as per the NCCN, should be tested, but generally in our clinical practice, we are not doing so. Testing to be done at metastasis, yes, it can be done if the metastatic site is accessible. Preferably a new biopsy to be done because it is enriched by around 4 to 5%. as compared to the old tissue. So we are able to catch 4 or 5% patients more. Somatic testing is definitely preferred over the ctDNA testing. And whether we would like to do a BRCA1-2 selective panel or whether we would like to do a complete HRR panel testing, everyone would agree that a complete HRR panel testing should be preferred. So this is the profound data which has already been discussed by Vikas. And definitely olaparib is showing a very good improvement in the radiographic progression-free survival and over the standard androgen therapy. And this benefit is there in the BRCA1 and 2 mutation patients or ATM mutation patients. And the maximal benefit is seen with the BRCA1-2 as compared to the other HRR panel mutations. So thank you very much. And I hope that we were able to drive in some points through this discussion. Over to the organizers for, I think so they have some new things to share in this.
Thank you, Dr. Rajat, for an excellent conduct of a panel discussion. Thank you all esteemed panelists for their expert opinion. And this is definitely an evolving topic of the molecular arena in prostate cancer, where to fit in the olaparib, where to fit in the molecular test. So it was rightly a nice consensus made in the end that definitely we'll have to rely on the either archival tissue, if available tissue biopsy other than the bone, then that could be utilized in a metastatic setting, as it enhances 4% in terms of the HRR availability, or probably it enhances from the archival tissue, as Dr. Rajat has rightly pointed out. So there's last one more question which is coming up. Remaining, no, it's not there. So with that, I mean, we had a night discussion on the prostate symposium, where we just concentrated on the prostate cancer. To start with, the talk on multidisciplinary approach was as it's very important in every cancer, and prostate more so. And down the line, the two talks by Abhishek as well as the Vikas, and two panel moderations, one by Surgeon and Dr. Rajat, comprehensively giving us the management portfolio in prostate cancer. With that, I thank you everyone for giving your time and to the symposium. Over to you guys. And also, I want to point out that the AstraZeneca is giving free of cost on the HRS testing. So I think we should use it. So the upfront, when we talk of whether it is upfront versus down the line, because now it is available free of cost, you can probably use it now as many as possible, even if it is upfront. So that's the point I want to make.
The organizers have some post presentation polling questions also.
Yes, sir. Support team, please.
So we can all just participate for a few seconds in this post polling. I think so. We all have submitted our responses.
Can we move to the second question, Surbi?
Yes, sir. Support team, please, next question.
Any other question is there?
Yeah.
The last one, please.
Next question, please.
Was it the last question?
Okay, I think so. There were 3 questions. We have answered all.
Next question, please.
Thank you, sir. Thank you so much for giving this opportunity and just doing this polling. It will be very insightful for all of us. Thank you so much, and good night to everyone.
Thank you. Thank you all. Thank you. Bye.
So thank you, everyone.
Good night. Good night, Dr. Chandra.
Bye-bye.
Good night. Thank you, everyone, for
Bye-bye.
joining and making the evening so
Thank you.
exciting.